Sexton, carpenter, armor, yada yada. It's 1865. Let's leave in May. As in, may I, for the love of God, actually make it to the end of the game this time. Ooh, oxen. All of them, please. Ammo, food. Wait, what the hell's a wagon tongue? Ugh. 2 dozen. Alright, Oregon Trail, you're mine. Well, that escalated quickly. But while the Oregon Trail may not be the most fun game, it very well may be the most educational. So, yeah, pretty terrible. But let's say we got really far along in the game. But then one of our party members started having bright red blood per rectum. Oh god, I don't remember that from the game. Do I trade some oxen for supplies, or am I supposed to go hunting? How do I fix this? This guy here seems pretty happy though. So I guess it's good that he's not in any pain. Anyways, this here's Lawrence, and he's, well, bleeding from his rectum. So, why is that happening? He's a 62-year-old guy. He's also denying any risk factors for bleeding, like anticoagulation, GI surgery, or previous bleeding episodes. And finally, labs all seem relatively normal. He's mildly tachycardic, but the rest of his vital signs are relatively normal, suggesting that he's not quite into hemorrhagic shock territory yet. So, what's up with Lawrence? Where is this blood coming from? Well, it's coming out of the rectum, so it's gotta be the GI tract. Well, there are lots of reasons why someone could have bleeding out of his gastrointestinal tract. Lower GI bleeding can be caused by a number of things, including, but not limited to, colon cancer, inflammatory bowel disease, ischemic colitis, hemorrhoids, etc. Well, that doesn't rule things out for Lawrence much. The most common cause of lower GI bleeding in adults, however, is diverticulosis. So let's chat about this to determine if this is what our old friend Lawrence has. Diverticulosis is a disease of diverticula.
Thank you, Ricky. Very insightful.
Yeah, shut up. Diverticula are sort of like pouches jutting out from the colon wall. So we've sketched in these literal pouches hanging off these colon-esque wagon covers. Diverticulosis is very common and increases with age, occurring in about 60% of people over 60. Luckily, most cases are asymptomatic and an incidental finding on imaging or colonoscopy. These colonic nubbins form when pressure inside the colon forces the mucosa outward through the muscularis, leaving a mucosal sac dangling outside the colon wall. Technically, colonic diverticula are false or Pulsion diverticula because the pouch doesn't involve the muscularis layer. Diverticula are most commonly located along the mesenteric border where penetration by the vasa recta vessels creates weak spots in the muscularis layer. Colonic diverticula are most common in the sigmoid colon, so in comes the sigmoid snake. This is because the sigmoid colon is the narrowest section of the large bowel, making intraluminal pressure higher and really putting the squeeze on the mucosa. Constipation leading to diverticulosis? Diverticulosis affecting motility and creating more diverticula? The jury may be out on what causes diverticula, but there's a clear association between the development of diverticula and two things: age and constipation. And, well, believe it or not, that sounds like Lawrence from our clinical case. I think we're on the right trail here. Trail. You see what I did there? This is why I have no friends. Symptoms of diverticula? Well, usually none. Which is why this wagoneer, equipped with the plushest of red stools, hasn't a care in the world. That being said, diverticulosis is the most common cause of painless hematochezia, though only about 10% of diverticula ever actually bleed. Bleeding is usually mild, simply causing maroon-colored stool, but can also be severe and even life-threatening. So why any hematochezia in the first place? The thought is that injury to the arterioles covering a herniating diverticulum leads to vessel wall weakness, sort of like blowing up a balloon wrapped in silly string. Eventually, the mucosa of the pouch erodes, the vessel walls break down, and we got a bleeder! Interestingly, although most diverticula are located in the sigmoid colon, diverticula in the right colon are more likely to bleed. To help you remember, we've put these red hoof prints next to this keep right sign, which, additionally, is right next to this flowing red river. This river you do not want to ford. Find a way around. This also makes for two different appearances of the blood in diverticular bleeding. Since blood from the right colon has to transit the length of the bowel, it typically gets thrown into the mix, creating, Let me think back to middle school art class. Red plus brown equals maroon colored stools. That's fun. Since left sided diverticular bleeding is so close to the anus, it typically presents with bright red blood per rectum, or BRBPR. That's a small distinction and it's not always perfect. In terms of our clinical case, it makes me think more left sided for Lawrence. But that doesn't really help much with the clinical question. Luckily, most cases of diverticular bleeding stop spontaneously, hence the sign. In cases of diverticular bleeding that don't stop on their own, however, there are a few treatment options available. As with most things colon, taking a look doesn't usually hurt. The endoscopist, that is. Colonoscopy can be performed to look for the bleeding diverticula, and from there, a few things are possible. However, if there are signs of inflammation, like fever, abdominal pain, or tenderness, you'll need to rule out colonic inflammation before scoping it out, as colonoscopy in an inflamed colon can all too easily result in perforation. If active bleeding is seen, the area can be injected with epinephrine or cauterized or pressure held with the endoscope itself. Furthermore, exposed vessels that look awfully suspicious but aren't bleeding yet can be cauterized to stop them in their tracks. Ah, here we go. So, probably for our clinical case, the answer is colonoscopy. Great job, everyone. We got there in the end. But it's not the end, is it? What if we couldn't find the bleeding part? Or worse, what if we found it but couldn't stop it? In many cases, colonoscopy isn't successful in stopping or even locating diverticular bleeding, like this guy having trouble locating the trail. In these cases, angiography may be performed. So we've sketched in our angio adventurer here right next to the lower GI flashlight. Angiography is useful because it's both diagnostic, i.e., locating the bleed, and therapeutic. If a bleeding vessel is discovered with angiography, it can either be coiled, which closes the vessel with a procoagulant coil, or injected with vasopressin to cause vasospasm and stop the bleeding. Problem is, angiography is only useful with active bleeding, hence the fresh cuts on our lost adventurer here. If the bleeding has already stopped, angiography won't help at all. If everything else fails to stop the bleeding, or the patient becomes hemodynamically unstable, surgery may be necessary. Segmental colectomy can be performed to remove the actively bleeding diverticulum, or diverticula, because sometimes there can be more than one diverticulum bleeding. In surgery, you don't have to remove all of the diverticulosis. You just have to remove the sections of colon that have the ones that are bleeding. However, bleeding will recur in about 25% of all cases, requiring intervention even if it wasn't required initially. In some cases, especially severe bleeds, elective colectomy may be considered after resolution of the acute bleed. Damn it, my axle's broken. And has apparently caused some pretty extensive damage over here. We've sketched in this unstable wagon scene to help remind you that if patients come in with hemodynamic instability from severe lower GI bleeding, workup is a little different. Luckily, this wasn't our clinical case because that would have been a bloody mess. But a little change in Lawrence's vital signs would make a very big change to the answer to our clinical question. First off, any patient with obvious blood loss and hemodynamic instability needs IV resuscitation with the red stuff. Though IV fluids while you wait for blood are always helpful. Whoa, Chief. You're not making it to Oregon if you keep leading your oxen like that. But since severe GI bleeding, i.e., enough to cause hemodynamic instability, is more common with upper GI bleeds, you should rule out an upper GI source with NG lavage. A small amount of water is instilled into the stomach through an NG tube, sits for a minute, then is suctioned back out. If there's red or coffee ground blood, it's more likely the patient has a brisk upper GI bleed and needs upper endoscopy, not colonoscopy. With colonic diverticular bleeding, expect to see the normal greenish NG suction, sort of like this green goo coming up when he pulls that nose ring. Remember that although melena is more common with upper GI bleeds, severe upper GI bleeds can also have bright red blood per rectum if there's enough fast bleeding to transit the GI system without getting digested. While colonoscopy is the test of choice for diagnosing and even treating most diverticular bleeds, hemodynamic instability is a contraindication to colonoscopy because, well, colonoscopy setup can be slow. The bleeding point is pretty difficult to identify when the colon is all full of blood. And especially for severe bleeds, colonoscopy may not be enough to stop the bleeding and therefore isn't definitive treatment. Patients who are unstable from diverticular bleeding should go straight to angiography or surgery. In many cases, angiography is both diagnostic and therapeutic for diverticular bleeding, especially when bleeding is brisk. In any case, any patient who presents with diverticular bleeding should undergo colonoscopy once stable. So put the scope in its holster. You'll use it, just not right away. All right, well, luckily we've fixed up Lawrence from our clinical case at this point. But we're not quite done with this sketch. A wise prairie man once said, "All that poops blood is not diverticulosis," and he was correct. Let's review another important cause of acute lower GI bleeding. Angiodysplasia refers to arteriovenous malformations and tortuous venous dilations that occur throughout the GI tract and especially the colon. They're typically very thin walled, dilated vessels composed of either endothelium alone or endothelium with just a skosh of smooth muscle, which is why we've sketched in this thin red tumbleweed with just a little bit of smooth muscle grass. As with diverticula, angiodysplasia is classically seen in patients over 60. Let this right colon cane remind you that while diverticula are most common on the left side, angiodysplasia is typically found in the right colon, especially the cecum. While the exact pathogenesis of angiodysplasia is unknown, there are some pretty strong associations, such as end stage renal disease, von Willebrand disease, and aortic stenosis. Aortic stenosis, represented here by our recurring sketchy symbol for aortic stenosis, a squeezing pointy hat, may actually cause an acquired form of von Willebrand disease due to destruction of von Willebrand factor by the shearing forces the diseased valve creates. While aortic stenosis may not cause angiodysplasia, the deficiency of von Willebrand factor created sets the perfect scene for bleeding, which would make you detect the angiodysplasia. In fact, the triad of aortic stenosis, acquired von Willebrand deficiency, and microcytic anemia from chronically bleeding angiodysplasia is known as Hyde syndrome. Aortic valve replacement, and thus relief of aortic stenosis, has also been shown to reduce bleeding from angiodysplasia. Not surprisingly, having good old fashioned von Willebrand disease from the start can also increase angiodysplasia bleeding. You're not going to get much done with these dysfunctional pulleys. In the same vein, uremia induced platelet dysfunction in end stage renal disease may also increase the risk of bleeding of an angiodysplasia and therefore detection. An important thing to remember is that the bleeding from an angiodysplasia is venous, which is generally much milder than the arterial bleeding seen with diverticulosis. However, while angiodysplasia bleeds are less severe, they tend to be recurrent and chronic. So, while you may not see the bright red hematochezia associated with diverticulosis, be on the lookout for occult blood loss and iron deficiency anemia in older patients, which should always lead to one thing: bring in the lower GI flashlight. Because colonoscopy should be performed in all older patients with hematochezia or unexplained iron deficiency anemia, to rule out colon cancer, of course. On colonoscopy, non bleeding angiodysplasias look like flat red lesions with branching blood vessels radiating from a central point. This gives them the appearance of an arborizing pattern or a cherry red spot. If an angiodysplasia is discovered endoscopically in a patient with a history of occult or overt GI bleeding, it's treated whether or not it's bleeding. This is because even if it's not bleeding during colonoscopy, it may very well bleed later, leading to worsening anemia or a severe bleed. Lesions can be treated endoscopically with argon plasma coagulation, traditional electrocautery, or old school techniques such as clipping or banding. Conversely, angiodysplasia discovered on routine screening colonoscopy in a patient without a history of occult or overt bleeding is usually not treated. If colonoscopy fails to localize a bleeding angiodysplasia, angiography may be performed. As with diverticulosis, angiography can be used to both localize a lesion and, if possible, treat it. And again, as with most things that bleed too much, surgery can usually stop it. In patients who are hemodynamically unstable or have a high blood transfusion requirement, segmental colectomy may be performed to prevent further loss of the red stuff. All right, let's review what we've covered. There are many causes of bleeding per rectum: colorectal cancer, inflammatory bowel disease, ischemic colitis, hemorrhoids. But the most common cause of bleeding per rectum is diverticulosis, which is the herniation of colonic mucosa, called diverticula, through weak spots in the colonic wall where the vasa recta perforates through the colonic wall. Colonic diverticula are considered false diverticula because they only involve the mucosa and submucosa, and not the other layers of the wall. The sigmoid colon is the most common location for colonic diverticula. Risk factors for diverticulosis include increasing age, chronic constipation, and colonic motility disorders. Diverticulosis is usually asymptomatic. However, a complication of diverticulosis is bleeding, which presents as painless hematochezia. Bleeding from diverticulosis is the most common cause of lower GI bleeding in adults. Typically, bleeding is mild and self limited. However, it can also be severe and life threatening. While diverticula themselves are more commonly located in the left colon, specifically the sigmoid, bleeding from diverticula is more common in the right colon. Colonoscopy can be used to identify and treat bleeding diverticula. Angiography is another modality for the diagnosis and treatment of bleeding from diverticula, but can only identify actively bleeding diverticula. Finally, if colonoscopy or angiography are unable to locate or treat the bleeding diverticulum, surgery may be performed in a segmental colectomy fashion. A caveat to diagnosis and treatment is hemodynamically unstable patients. Colonoscopy is contraindicated in these patients. They should be brought directly to angiography or surgery while actively undergoing resuscitation with IV fluid and, most importantly, blood products. In unstable patients, nasogastric tube placement and NG lavage may be used to rule out a severe upper GI bleed. Although hemodynamic instability is a contraindication to colonoscopy in the acute setting, patients with diverticular bleeding should still undergo diagnostic colonoscopy after stabilization. Angiodysplasia is another cause of lower GI bleeding. Angiodysplasia involves arteriovenous malformations and tortuous venous dilatations that occur throughout the GI tract and have a tendency to bleed. Angiodysplasia is more common in patients over 60 and is more commonly located in the right colon. Angiodysplasia is associated with end-stage renal disease, von Willebrand disease, and aortic stenosis, which can cause acquired von Willebrand factor deficiency. Bleeding from angiodysplasia is typically slow and low volume and is typically venous. This results in chronic bleeding that may be either occult or overt with hematochezia. It can also be associated with iron deficiency anemia. Colonoscopy is necessary for diagnosis and possible treatment and to rule out colon cancer. Angiography may also be used for diagnosis and treatment. If the bleeding is severe or unable to be located or stopped by these methods, surgery may be necessary, though this is rare. Great job, everyone! We've successfully made it halfway through the Oregon Trail. Head on over to our sketch on acute diverticulitis for the second half of this wild, wild west quest.